Welcome to the 5-Minute ECG Consult, brought to you by myself, Sungyoung Hiva Lee, and Dr. John Hayden, co-author of ECG for First Responders, available on Amazon. Over the next few publications of the ECG 5-Minute Consult, we'll be running a series known as the 10 Deadly Signs on ECG, abnormal findings that must not be missed. We will highlight 10 potentially lethal ECG patterns that may go unrecognized. Awareness is the first step in preventing cardiac disasters. You arrive on scene responding to an emergency call for a 59-year-old construction worker. He complains of mild chest pain that began 30 minutes ago. He describes the pain as squeezing feeling that extends up his left shoulder. He's slightly diaphoretic, with blood pressure of 156/94 and 14 respirations per minute. He's reluctant to be transported to the hospital by ambulance because of the cost, and his pain is going away. His past medical history is significant for hypertension, osteoarthritis, and high cholesterol. His medications include 1 dose of sublingual nitroglycerin that seems to be resolving his chest pain, lisinopril for hypertension, and atorvastatin for hyperlipidemia. We use the ECG primary survey approach to quickly identify potentially life-threatening emergencies. Using this approach, first responders should be able to address these 4 questions. 1. Is the heart rate too fast or too slow, causing cardiovascular instability? 2. Is the rhythm supraventricular or ventricular in origin? 3. Are the ST segments consistent with an ST elevation myocardial infarction or a non-ST elevation myocardial infarction? And 4. Are the T waves consistent with a STEMI or an NSTEMI? With this in mind, let's take a look at our patient's ECG. First, let's examine the rate. You can estimate the heart rate by applying the 300, 150, 100, 75, 60, 50 sequence. Because the peak R waves are approximately 5 large boxes apart, we can quickly estimate the rhythm as 60 beats per minute. You can estimate very slow rhythms by counting the number of QRS complexes that occur in a 6-second time period, 30 large boxes, and multiplying by 10. Since this patient's vital signs do not suggest compromised blood pressure or other signs of shock, it appears that the rate is not causing any cardiovascular instability. Next, let's look at the rhythm. As you can see, the QRS intervals are narrow, as seen in lead AVL right here. Because the QRS intervals are less than 3 small boxes, we can deduce that the rhythm is supraventricular in origin. Next, let's examine the ST segments. The ST segments appear normal, that is, they rest on the baseline of the ECG. Remember, the ST segment elevation or depression in a minimum of 2 side-by-side leads may indicate a cardiovascular event. The leads overall appear unremarkable for acute ST segment changes. Lastly, let's look at the T waves. The T waves are inverted in leads 1, AVL, and across all chest leads, as you can see here. Remember that T waves are normally upright in all left-sided ECG leads. Let's test your knowledge. Which of the following is the most appropriate response to this patient? A. Although your ECG looks okay, we strongly recommend transport to the emergency department to be on the safe side. B. Your insurance will cover the cost of the ambulance, so don't worry about that. C. We can't force you to go to the hospital. If your pain gets worse, call us back or have someone drive you to the hospital right away. D. Your ECG doesn't look like you're having a heart attack. Rest, but call your primary care doctor as soon as possible. Or E. Your ECG is not normal. We strongly advise you to be evaluated in the ED. The correct answer is E. Your ECG is not normal. We strongly advise you to be evaluated in the ED. Let's discuss why. This patient is presenting with a potentially lethal condition known as Welland Syndrome. Welland Syndrome is a pattern of deeply inverted or biphasic T waves in the anterior precordial leads, seen especially in V1 through V3, highly specific for a critical stenosis of the left anterior descending artery. Isoelectric or minimally elevated ST segment elevations may be present as well. Patients may be pain-free by the time these ECG changes are visualized. They may have normal or minimally elevated cardiac enzymes when seen in the hospital. However, they are at extreme risk for extensive anterior wall myocardial infarction within the next few days to weeks. Welland syndrome represents a true cardiac emergency. As mentioned on the last slide, the two T-wave patterns seen in Welland syndrome are pictured below. Type A is a biphasic, initially positive then transitioning to negative terminal activity, and type B is an inverted, deep symmetrical T waves, as seen in our patient today. Here are the Welland syndrome high yield points. Don't be fooled. Remember, Welland syndrome is a potentially lethal condition that can lead to sudden cardiac arrest. The ECGs of the patients with Welland syndrome can look benign, but be aware of the inverted or biphasic T-wave patterns. Despite high risk for an MI, the patient can present with mild, minimal, or even no chest pain. The ECG changes seen in Welland syndrome indicate high-grade stenosis of the left anterior descending artery, the coronary artery often referred to as the widowmaker. This artery provides a significant amount of blood to the left ventricle and septum. Welland syndrome qualifies as a STEMI alert, despite the absence of typical STEMI signs on ECG. The patient must undergo emergency PCI and cannot be mistaken as a less urgent patient only needing maintenance with heparin, aspirin, etc. So this wraps up the first segment of the 10 deadly signs on ECG, abnormal findings that must not be missed. Remember Welland syndrome. Look for the biphasic and inverted T waves and a minimal physical presentation. That wraps up today's segment of the ECG 5-minute consult. For more information about our primary survey approach, check out ECG for First Responders, available on Amazon. See you next time.